Welcome to the US Sonar video demonstration for the ankle joint. We'll begin with the anterior longitudinal view. For this view, we'll position the proximal edge of the transducer along the distal tibia, and the distal edge of the transducer will point to the web space between the first and second toe. With the transducer in this position, you should be able to see the distal tibia, the talar dome, and the talar neck. You will then want to scan medially and laterally along the anterior ankle, and you'll need to rock the transducer as you go, trying to keep the bone of the talus nice and sharp. Notice this normal fibrofatty tissue in the triangle made by the joint cleft between the tibia and the talus. In the case of an effusion, this will be replaced by anechoic or hypoechoic material, and it may layer anteriorly along the talar dome and towards the neck of the talus. Normally you should be able to see the articular cartilage here in black, and you may see a reflection off the articular cartilage. More superficially, you can see the extensor tendons, and if you scan a little bit more distally, you'll see the talar navicular joint cleft right here. After you've imaged the entirety of the tibio-talar joint, you can point the transducer in a transverse orientation, and again start at the tibia, a bone that you can palpate, and then start scanning distally. When the tibia falls away, point the transducer more inferiorly, and you will see this bright line of the talar dome. You will see the cartilage, and superficial to that you'll see the dorsalis pedis artery, and you'll see three tendons here: the tibialis anterior, the extensor hallucis longus, and the extensor digitorum tendons here. And keep scanning distally. You'll notice the articular cartilage fall away. Now we're over the talar neck, and then if we keep going, we'll get to the articulation between the talus and the navicular right at that point. So that's the anterior scan for the ankle. We can then go on to the medial ankle scan. For this, you can externally rotate the leg, or you can have the patient positioned on their stomach, and from that position you can access the medial, lateral, posterior, and inferior aspects of the ankle. For the transverse scan, go ahead and palpate the medial malleolus and put the anterior part of the foot on the left side of the screen this way, and point the posterior aspect of the transducer at the Achilles tendon. And what you should see is an image like this, with the tip of the medial malleolus, the tibialis posterior tendon, and the flexor digitorum tendon here. And I'm going to decrease the depth so that we can see these tendons in better detail. So again, the tibialis posterior tendon and the flexor digitorum tendon here. The neurovascular bundle, usually with a couple of veins and an artery, and the posterior tibialis nerve. And then further posteriorly you'll see the flexor hallucis tendon and muscle. If you're relatively proximal on the malleolus, you'll see quite a bit of muscle and just a little tendon. If you scan more distally, as the malleolus is going to start to disappear, you'll see that the muscle also disappears, and you're left with just the flexor hallucis tendon. Okay, so again, the flexor hallucis tendon, the posterior tibialis nerve, the neurovascular bundle with the veins compressing easily, the artery not so much, flexor digitorum tendon, and the tibialis posterior tendon. Try to look for any tenosynovitis in the tendon sheath around the tibialis posterior. Look for any irregularities along the medial malleolus that could be indicative of erosive disease. Following this transverse view, go ahead and get a longitudinal view. Start by positioning the transducer right along the malleolus, so right on the malleolus where we cannot see a tendon, this way. And then slide the transducer posteriorly. Here's the tip of the malleolus here. I'm going to slide posteriorly until I see a tendon. That's got to be the tibialis posterior tendon in this position. And I'm going to start to point the transducer posterior to anterior and slide more posterior as I go. I'll slide off the tibialis posterior, and I know that the next tendon to come into view is going to be the flexor digitorum. If I keep sliding more posterior than that, I'll get into the neurovascular bundle, which you see here. And then if I keep going posteriorly, I'll get into the nerve here. And then more posterior still, we'll get into the flexor hallucis tendon. If you're not sure if this is the flexor hallucis tendon, go ahead and flex and extend the toe, and you'll see it move if you're indeed over the flexor hallucis. And now we've assessed all of these same structures in a longitudinal view. The next scan will be the inframalleolar longitudinal scan. For this one, palpate the navicular tuberosity, which is right here, and position the distal edge of the transducer right on that bony landmark. So there it is. So this is the navicular tuberosity. I'll then point the proximal edge of the transducer at the tip of the malleolus, and that will bring the tibialis posterior tendon into view. To get a better image of it, I'm going to point from a inferior to superior position, and I'm going to put the ankle in a little bit more eversion. So now you can see that the arrow is pointing to the PTT attachment to the navicular tuberosity. This is a spot where you can look for enthesitis and erosive disease of the navicular tuberosity. You might see Doppler signal at this point. And then if I adjust the proximal edge, I can then follow the PTT tendon, seeing if there is any fluid in the tendon sheath, until I followed it all the way back to the medial malleolus. Now I've viewed the entirety of the PTT tendon. Notice that just deep to the PTT tendon is a spring ligament. You can sometimes see inflammation of that ligament in inflammatory disease. So that's the medial ankle. For the lateral ankle scan, the principle is the same as for the medial scan. You'll want to palpate the lateral malleolus and then put the anterior aspect of the ankle on the left side of the screen, and then the posterior aspect that points straight back at the Achilles tendon is going to be to the right. So here you can see the lateral malleolus, and you can see the two tendons here, the peroneus longus and the peroneus brevis. They sit one right on top of the other at the proximal malleolus. The one that's closer to the bone is the peroneus brevis, and then we can follow them distally. Notice this is the muscle of the peroneus brevis, and this is going to become smaller as we go distally. I'm going to rock to make the peroneus brevis go from dark to bright with anisotropy until we follow these two tendons past the malleolus. and we can stop at that point. We want to see if there's any tenosynovial effusion, if there's any irregularity of the fibers, or any hyperemia around them with our Doppler. After the transverse, we will again look in longitudinal view, starting at the lateral malleolus and then scanning posteriorly. Here you can see the two tendons, the longus and the brevis. Ideally, you want to put the transducer in sort of a posterior to anterior orientation, and in this way you can image both the tendons and the underlying bone. So here they are. You can see the tendon and the bone, and you want to adjust the axis of the transducer until you see the tendon go all the way across the screen to the tip of the lateral malleolus. There's one tendon, here's the other. There is also an inframalleolar scan, so just like on the medial side, on the lateral side, the peroneus brevis attaches on the fifth metatarsal. So I'm going to put the distal edge of the transducer right along on that bony prominence and find it on the screen right here. You can see that there's a tendon that attaches to it. This is the peroneus brevis, and then all I have to do is adjust the axis of the transducer until I can see that whole tendon, and I can follow it back all the way to the lateral malleolus. Okay. The longus dives deep, so this is going to be the longus. It does not attach on the fifth metatarsal. It's going to go underneath the side of the foot and insert on the undersurface of the first and second ray, and we generally do not image the full length of the peroneus longus. We'll just image it to this point where it makes the bend. And that's the lateral ankle scan. For the posterior ankle scan, go ahead and position the distal edge of the transducer right on the calcaneus and the proximal edge along the Achilles. Your goal is to see this bony landmark and want to make it nice and bright. You want to see if there's any fluid in the retrocalcaneal bursa region right here. If there's a little drop of fluid that does not extend past the most proximal edge of bone, that's probably still normal. Anything past this point would be abnormal. You can image the bone more distally. In this first third of the calcaneus, you might see erosions and an enthesitis. In the more distal aspect of the insertion, you might see osteophytes, and you may run into problems with anisotropy of the Achilles tendon if the foot is not in dorsiflexion. More proximally along the Achilles, you're more likely to see mechanical disease in this region. You could also see rheumatoid nodules or tophaceous deposits in the Achilles tendon anywhere along its length. Once you've imaged it in the longitudinal view, go ahead and turn to a transverse view, and we're going to align along the Achilles tendon. We're going to make it as bright as possible and scan distally, making sure that all the fibers of the tendon are homogeneous and one side of it looks like the other. Here we have the calcaneus coming into view. Notice how straight across this bright line of the bone is. There are no erosions or cortical irregularities in it. And we can go ahead and follow the tendon and adjust the transducer angle to try to make it bright until we get to the end of the insertion. The last view in the ankle is of the plantar fascia. For this view, we'll want to put the more proximal edge of the transducer right on the heel, and I'm going to increase the depth, and I'm going to increase the deep gain to make the tissues brighter. We frequently have to do this when we're imaging the plantar fascia due to all the keratin we're having to scan through. So this is the bottom of the calcaneus now, and this is the plantar fascia insertion. I'm pointing the distal edge of the transducer to the space between the first and second toe. This is where the plantar fascia is going to be thickest, and if we wanted to, we could measure the thickness of the plantar fascia. This is the more deep side and the more superficial side of the plantar fascia, so this would be the AP diameter, and we can follow it distally if we want, although most of the pathology we're going to be looking for will be right at the origin. Again, we're looking for an erosive change or Doppler signal at the origin of the plantar fascia to be indicative of an inflammatory condition. If you see any abnormalities, you can go ahead and get that image in transverse as well. Otherwise, just the longitudinal will suffice. And that's the end of the ankle scan.